Hello, everyone, and welcome to our Newborn Screening and the Early Hearing Detection and Intervention Program, What Families Need to Know workshop with Linda Hazard, Program Director for the Vermont Early Hearing Detection and Intervention Program, and Sydney Williamson-White, the Nurse Program Coordinator for the Vermont Newborn Screening Program. Vermont Family Network has been serving families of children with special health needs and disabilities and the professionals who serve them for more than 30 years. We are the federally designated Parent Training and Information Center, the Family-to-Family Health Information Center, and the Vermont chapter of both Family Voices and Parent to Parent USA. I'm excited to introduce you to Linda Hazard and Sydney Williamson-White. Thank you both so much for joining us today.
Hi, I'm Sydney Williamson-White, the Nurse Program Coordinator with the Newborn Screening Program in Vermont. And we're here today to give a brief overview of newborn screening in the state, mostly dried blood spot newborn screening as well as hearing screening. Next slide. So today we're just going to be providing an overview of the Vermont Newborn Screening Program, discussing what families can expect when they're newborn screened, and then also just reviewing briefly some of the health problems that newborn screening tests for. Next. So what is newborn screening and why is it done? It's actually a relatively old public health program in our country. It started in the 1960s with Dr. Robert Guthrie, who discovered a way to test for phenylketonuria using dried blood spots. And using this platform made it easy to expand screening across the nation, with Massachusetts being the first to mandate screening. And why this was important was that diagnosing babies with PKU early helped prevent severe illness because treatment could be started right away. And now we have even more health problems that can be found through newborn screening. But the main idea is the same. The main goal is to find rare health problems early so that newborns and their families can get the support and care they need. When treatment can be started early for a lot of conditions, this can really improve health outcomes and save lives. And newborn screening is not just a test, it's also a system. So we're involved with follow-up to make sure that the health care providers get the results and that the babies get into care quickly, and that all the proper steps get completed. We also do education, and we also do quality assurance to make this program the best it can be. Next. And so one thing I want to mention here is that newborn screening is more than a PKU test. You might hear this language. Some healthcare providers will still call it the PKU test, just because PKU is the first newborn screening condition on the panel. So it's really important to get clarity from your healthcare provider if they say that, this is the PKU result, or the PKU result was maybe abnormal. It's good to know what exactly we're talking about, because dried blood spots are actually tested for PKU, but also 32 other conditions. And then newborn screening also includes hearing screening, which Linda will talk about later, and then heart screening. And both of these are done separately and in the hospital. Next slide. So how is screening done when we're talking about the dried blood spot screening? So a healthcare professional, usually around 24 to 48 hours of life for the baby, will use a small device to make a prick on the baby's heel, and they'll take the blood and they'll apply it to a special filter paper and just fill a couple circles of blood. And then they'll make sure the baby's name, birthday, and all the other important information is on that paper, and then that goes to the newborn screening laboratory where they run all the tests. Next. And so you might wonder why certain conditions are part of the newborn screening panel and why some are not. There's the recommended uniform screening panel in the United States, and those conditions are determined by a group of experts. They have a very long name, the Advisory Committee on Heritable Disorders in Newborns and Children. And they review conditions that have been nominated to become part of the screening panel. And then the Secretary of the Department of Health and Human Services reviews the committee's recommendations. And they consider a lot of things when they decide if a condition should be added. They think about, is there a reliable test for the condition? Is the condition well understood? And I put relatively here in parentheses because sometimes when we screen, we learn even more things about a condition that we didn't know previously. And then we also wonder if there's an effective treatment and would the condition be easily recognized without screening? And we're mostly looking for conditions that would be found in the early newborn period. So these aren't all the things they consider, but it's just an example. And then once the condition's been recommended to the recommended uniform screening panel, states will then decide whether or not to add the condition in their own state. Next slide. So here's a brief overview of newborn screening in Vermont. We actually screen for all the RUSP conditions, so 35 in total, and 33 of these are tested by the dry blood spot. The other 2 is going to be the hearing and heart screening, which are done in the hospital or at home if the baby's born at home. And as I said before, not all states are going to screen for the same conditions. Some screen for more than the RUSP, some screen for less, and every state's program is run a little differently. In Vermont, we recommend that all babies should be offered screening. It's part of our administrative rule in the state. And it's really recommended as part of normal newborn care unless the parent or guardian does not want the test to be done. Next slide. So the family will get the results of the newborn screening tests after a few days. The specimen or the blood spot needs to go to the lab. The lab needs to run the tests and then report them out to the state program, which then reports them out to the healthcare provider. The primary care provider will get the results as well as the hospital where the baby was born. We do send these to the midwife if the baby's born at home. If the results are abnormal, we will call the healthcare provider or the hospital if the baby's still in the hospital and let them know about the results. And we'll usually give them recommendations such as, next steps. And it's also important to know that not all abnormal tests mean that a baby has the condition. Sometimes the results can be abnormal for other reasons. And it's really important to make sure that you know the results of your baby screening tests. It's okay to ask for the results at the newborn visit if you haven't heard anything. And then the hearing and heart results can be given right after the screening is done. Next slide. So if the results are abnormal, you'll hear that from the baby's healthcare provider, and it's really important to follow their recommendations. And as I said before, not all abnormal results mean that the baby has a health condition. There are a lot of reasons why a result can be abnormal. This is a screening test. It's not a diagnostic test. So it means that the baby might be at risk for the condition, but more tests are needed to know if the baby actually has the condition. And sometimes all that's needed is a repeat newborn screen to recheck, or sometimes the baby might need more testing or a visit with a special type of healthcare provider. But regardless, it's important to take all abnormal results seriously and follow up on them. Next slide. So here are some things that newborn screening cannot do. I think sometimes people are not exactly sure what the limitations of newborn screening are. So newborn screening is done after the baby's born. It can't tell before the baby's born whether or not there might be health problems. It's not a test to see who the baby's biological parents are, and we can't check for all health problems. We just check for the 33 that are part of the panel. And as I said before, it's not a diagnostic test. They can only screen. Usually more tests are needed to determine whether or not a baby has a condition. Next slide. And you might wonder what happens to your baby's blood spot after we're done with testing. So they're kept in the laboratory for 1 year and then they're destroyed. They can be destroyed sooner or kept longer if the parent or guardian wants to send us a written request. We never use blood spots for research or experiments, but if the baby is enrolled in a research study or there's concerns that the parent has and wants further testing, we can send them the dry blood spot as long as we still have it. We just need a written consent. And the only way we do use the dry blood spots is occasionally if the lab needs to do quality control, so double checking the results or something of that nature. Next slide. If you don't want your baby to have the tests, we do recommend talking with a healthcare provider to go over the risks of not having the tests. We also encourage you to call the Vermont Newborn Screening Program with questions. We're happy to talk with you. And if you don't want the test, we do need a signed form, just stating that you understand the risks of not having those done. But newborn screening really is very important. It can save lives, and it's part of regular newborn care. And in Vermont, we have very few people who don't want these tests for their babies, well under 1%. So please feel free to ask questions. And thank you very much. Next slide. And if you have further questions, here are some resources that you can look into, and you're welcome to call our program. Next slide. Next slide, thank you.
Good afternoon, this is Linda Hazard, and I am the Program Director for the Vermont Early Hearing Detection and Intervention Program, and we'll be talking about newborn hearing screening, diagnosis, and entrance into early intervention. Next slide, please. So, who are early hearing detection and intervention programs? There is one of us in every state and territory, so there are 59 programs. They started in the early 2000s after a statement from the Joint Commission on Infant Hearing in 1999 that included the Academy of Pediatrics, audiologists, hospitals, and other interested parties. Currently, there is federal legislation that encompasses early hearing detection and intervention programs across the nation. Initially, Ed.D programs were really looking at birth to 6 months of age, and now have expanded in the most recent legislation to include up to 3 years of age. So what are our funding sources? Our funding sources include the Health Resources Services Administration under Maternal Child Health, the CDC, the Center for Disease Control, and some state funding. So I often will call HRSA our touchy-feely funds, and the CDC is really our database and our assessment piece of the funding. Next slide, please. So Vermont Ed.D, who are we? So we work with hospitals and other community providers. So screening is completed in the hospital, as Sydney mentioned earlier. And then we also started partnering in 2010 with our home birth midwives to ensure that babies born at home also received hearing screening. The Vermont Ed.D program provides equipment to the home birth midwives. We also collaborate with primary care providers, audiologists, early intervention, and we also support our primary care providers for early periodic hearing screenings up through age 3. So as a program, we provide support, training, and care management to families, their babies, and community providers. So if your baby has a hearing screening in the hospital and does not pass that hearing screening, the Vermont Ed.D staff, which is comprised of 2 full-time audiologists, a data manager, and a part-time administrative person. We will be care managing, we will be calling you, we will be talking with your primary care to ensure that your baby receives either a second inpatient screening or an outpatient rescreening. Next slide, please. We also engage families, audiologists, and early intervention providers. As part of our HRSA funding, grant funding a few years ago, it became We realized how important it was to ensure that we had family voices at the table around some of our documents, our letters, our pamphlets, but in general about how we could better support families as they're going through this process if their baby has not passed a hearing screening. Currently, we partner with family-based organizations such as the Vermont Hands and Voices, and all of our work is ensuring that non-biased materials and information is there for families to review, whether it's about technology that their child could use, or if it's about a communication choice, such as American Sign Language or listening to spoken language, or a combination. We collaborate closely as a program with early intervention and children's integrated services. Part of our job is to ensure that families receive information about early intervention providers and are enrolled in receiving services, hopefully by 6 months of age. We work with state, regional, and national agencies and organizations to achieve the national Ed.D goals. And during the COVID-19 pandemic, Vermont was one of the programs that met regularly with our federal and national partners. Next slide, please. So for us, it's all about the babies and the children. Next slide. So what are the goals and recommendations? They're often referred to, and you will hear them as 1, 3, 6, and beyond. So our first goal is to screen all babies before 1 month of age, diagnose or rule out hearing loss by 3 months of age, enroll in early intervention by 6 months of age, screen all children who pass newborn hearing screening in both ears, but who have risk factors for developing hearing loss in early childhood. So that's where really the age 3 has come in. And how do we do that? Through our community partners. Next slide, please. Why do we screen babies for hearing? So many years ago, before the JCIH position statement, the average age of a child with hearing loss that was identified was around age 5. And now, with the introduction of early hearing detection and intervention programs in newborn screening, those babies, for the most part, are identified in their early newborn period. So there are 2 to 3 babies in every 1,000 infants born that have some degree of permanent hearing loss. One of the most interesting factors of recent years is that we see a number of babies, at least 1/3 of the population, both in Vermont and across the country, with a hearing loss in 1 ear. Early childhood screenings are equally important, and that's one of the reasons that we partner with Early Head Start, we partner with primary care, is because another 2 to 3 children for every 1,000 children ages 6 months to 5 years have a late onset permanent hearing loss. That can be related to illness, injury, genetic factors. Half of these children have identified risk factors at birth. Next slide. So what are some of the risk factors? Family history of hearing loss. And that does not include a person who has developed hearing loss as they've grown older. But some families will have a generational hearing loss that's present. Some will have some family members that have had hearing loss since early childhood. Another risk factor is spending greater than 5 days in the NICU. Cleft lip and cleft palate. Syndromes, for example, like Down syndrome. Cytomegalovirus, CMV. Parental concerns, and Zika virus. And one I want to go back to for just a moment is the parental concerns. Anytime a parent has concerns about their child, they should have their child rescreened, even if they have passed a newborn hearing screening. Next slide. So these are some of the resources that you can find on our website. Say Yes to Early Intervention, information on Hands and Voices, and also the National Center for Hearing Assessment and Management, which is the National Technical Resource Center for all Eddie programs. And if you have any questions, please feel free to reach out. I would be happy to answer them. Thank you so much for your time today.
Thank you so much, Linda and Sydney, for today's informative workshop. You'll see a link to an evaluation for this workshop on our VFN Genetics Series website post. Please take a few minutes to complete it so we can make improvements and fulfill our grant requirements. We have tons of information and links to many other interesting workshops on our website, vermontfamilynetwork.org. You can follow us on Facebook or join our closed Facebook page if you are a parent. The name of the closed Facebook page is Vermont Families of Children with Special Healthcare Needs. You can also sign up for our monthly e-news or check out our YouTube channel. We're here to help, and getting connected with us is easy. Thanks again, everyone, and have a great day.